Perfect. We're on our way. So welcome to the February social work office hours. So this meeting is being recorded. So along with the recording, there will be the slide deck uploaded to our website. So for everyone who wasn't able to attend in person, they can view the information afterwards at their leisure. That is located at the SNP office hours website within the HCPF website. Definitely feel free to use the chat if you guys have any questions, raise your hand, come off mute, whatever you guys are comfortable with. If you're listening by phone, press *6 to unmute or *9 to raise your hand. Closed captioning is always available by hitting the CC option. And then, yes, if anyone needs accommodations, please email our accommodations email listed on this slide ahead of time, and we will definitely love to help provide any accommodations that you guys need. And then for today's meeting, we have the first presentation will be on the Regional Center background and overview by Kelly and her team. We're really excited about that. And then we also have Casey presenting on remote services guide, because I know that was a topic that was requested by different people who attend this meeting. So Casey, we're glad to have you as well. And I think Kelly and your team, you guys are first up. If you guys want to introduce yourselves.
Sure, thank you. And you have our slides. Wonderful. So this is just our kind of first slide that announces our team, and we're actually called the Community Services Team. I'm the Community Services Director. So I work with all three regional centers, and my office is in Wheat Ridge at the Wheat Ridge Regional Center. We can talk about each regional center when we go over our presentation. Um, yeah, do you want to go next, Lisa? We might as well do all our intros.
I'm Lisa Turk, and I am a placement coordinator. I also work for all three regional centers, and I am based at Wheat Ridge Regional Center.
And
Kelly.
good afternoon. My name is Kelly May. I'm the Community Services Manager at the Division of Regional Center. So work for all three, also based at Wheat Ridge. Some of our team members from the other regional centers just couldn't make it today.
Thank you. And then we can do I tell you when to do the next slide? Okay, thanks. So this is just a draft agenda. First, we'll go over the overview of the regional centers, just kind of what the regional centers are, some information about them, some myth busters. Second, some of the services that are provided at the regional center. And then finally, about our specific team, the community services team, the things that we help coordinate: admissions into the regional centers, transitions when someone's moving out, and then our community support team consultation model. We'll talk more about that too. Thanks. And I should have said, if anyone has questions, I think there's the hand feature and then the chat. So maybe while each of us are talking, like when I'm talking, Kelly and Lisa could look at that, and then when we rotate. But I think we're all good with questions during, but we'll also open it up at the end. So not knowing the background you all have with the regional centers, definitely chime in if there's questions, but there's three regional centers in Colorado, one in Wheat Ridge, one in Grand Junction, one in Pueblo. And so we actually have placement coordinators at each location. So Lisa is a placement coordinator based out of Wheat Ridge, and we have one other staff there. And then in Grand Junction, we have two placement coordinators, and in Pueblo, we have one placement coordinator. And then we also have a member of our team in Grand Junction who's a guardianship specialist. So the regional centers are considered a provider of last resort for adults with IDD who are in crisis and need a higher level of care. So people accepted have really tried, their teams have looked for, and the person has tried a variety of different options in the community, and those have not been successful, mostly for behavioral reasons. And our team, we review those referrals, and I think we'll talk about that later, but to determine if somebody meets criteria for admission. So it's really people in crisis who have nowhere else to go. The regional centers are considered institutional level of care. They don't look like that, but that's what they're considered. So we want to make sure that there's a good an exhaustive search in the community before somebody's admitted. People who are admitted have an imposition of legal disability, and we put the acronym ILD. It's part of state statute and required for any regional center admission. It's a court order, in case you haven't heard of it, that takes away a person's right to choose where they live, and it's in place while they're admitted. As of, and I think Kelly will go into this more, but as of 2013, the regional centers became short-term stabilization models. So prior to that, people could be admitted and stay forever. Now people are admitted and there's transition criteria developed, and then we help people transition when they've met that criteria. Individuals the goal is always for them to return to the community in more integrated settings. Individuals have the right to refuse medications and treatments. And then we just put that in there because some people think that we can force medications and the regional centers can't do that. And then our team, community support or community services team, we can provide community support consultation to hopefully mitigate the need for admission. So it's not that we don't think the regional centers do a great job, but since it's such a last resort, we want to try everything we can for people to stay in the community. Any questions so far? Okay. Well, we have some fun pictures too, but we're calling this slide Mythbusters, and we developed this just based on things we've heard that aren't true. So we wanted to clarify in case you've heard any of these. All of the group homes, and I should have said the regional centers all have group homes in the community. So even though it's an institutional model, it doesn't look like people don't live in a building or anything like that. It's actual homes in the community. They're not locked, and some have alarms, some have a mechanism that the door locks for a certain amount of time till the staff can intervene before somebody runs away, but they're not locked. So people, I think that is definitely a myth. There's not a waiting list. So the admissions are based on individual cases and where there's an appropriate placement at each regional center. People can't choose the regional center, meaning in the community, if you need to move from one home to another, you have options you can choose from, and you can say, oh, I want to go to this host home or this group home or this placement. With the regional centers, people can't just say, I want the regional center. Guardians can't say, I think my person needs to come into the regional center. It's really based on the referral that we get. Regional centers aren't psychiatric facilities or skilled nursing facilities. We do have medical services, and that's on another slide. And we do provide psychiatry and medication services, but we're not a psychiatric facility. So we can't give emergency IM psych meds or use mechanical restraints to hold somebody down. We can't administer court-ordered medications. And this one's more just, I don't know if you've ever heard this, but we're not part of the criminal justice system. So a judge can't order somebody to live at the regional center, or it can't be sort of a compromise. Instead of jail, they can go to the regional center. We're not really part of that process. We want that process to play out. And then guardianship is not required. So someone turns 18, they don't have a guardian, they're in custody with either their parents or somebody else till 18. They turn 18, they don't have to have a guardian. Some individuals with IDD can make their own decisions, and so they can still be admitted.
All right, I'll shift us over to talk about our funding and licensure, just so you have a perspective of how we are funded. We are funding through Medicaid. And we have 2 licensure levels. Some of our group homes, specifically at Pueblo Regional Center, and some of the group homes located at Grand Junction Regional Center, are actually licensed on the Home and Community-Based Services waiver under the developmental disability waiver. And so that just means that's how we are funded. Those are the rules and regulations those group homes comply with. Still considered more of an institutional setting as far as the level of care, but it is considered home and community based. And we have a negotiated rate with HCPF to provide a little bit higher level of care than you might traditionally see in most settings on the DD waiver. And then we have our intermediate care facility for individuals with intellectual and developmental disabilities. And so that is our true institutional level of care. All of Wheat Ridge Regional Center and part of Grand Junction Regional Center have ICF licensed homes. And so these are the more traditional institutional settings. As Jen mentioned, way back in the day, ICFs did look like institutions. When people think of institutions with big brick buildings, everyone's kind of living in this setting. Everyone's been transitioned to group homes because we're trying to be as integrated and person-centered as possible. So to be admitted to a regional center, you also need to meet Medicaid eligibility criteria. Next slide. Our treatment model. So Jen alluded to this a little bit too. So we are currently operating on a short-term treatment model. So anyone admitted after 2012. signs a short-term agreement. They're agreeing that they're going to be there for the time they need to stabilize and meet their transition criteria, which is heavily individualized, but it's basically determining which behaviors, like challenging behaviors or needs, are preventing this person from being safely served in HCBS services. Once they meet their transition criteria, we're going to help them transition back to the community because we want them to be in the less restrictive, community of choice. And so that means an individual or if they have a court-appointed guardian, they can't choose to remain at the regional center once that transition criteria is met. We're going to, move through that process. Next slide. We also have what we call an intensive treatment model. So our intensive treatment program is specific to individuals that are demonstrating some problematic sexual behavior, and they haven't been able to be safely served in the community. Like their supervision and treatment needs just can't quite be met in the community setting. This is a program that's very specific to Wheat Ridge Regional Center. So they do specialize and they have a separate program for individuals with problematic sexual behavior. There are specific group homes that are targeted just for this population. So, a lot of our group homes have different mixed diagnoses and needs. The group homes specific to this population are all individuals who are kind of needing to work on more appropriate sexualized related behaviors. And we do have a sex offense management board or SOMB certified therapist that works with these individuals that are enrolled in this program. Next slide. I'll hand it off to Lisa.
Thank you. Regional center goals. We already spoke about being person-centered. We're treatment-focused, and we provide short-term stabilization for everybody admitted. We support individuals so they have the opportunity to live in the most integrated and least restrictive community settings. Ensure transitions to community are well planned and assist individuals with adjusting to the new environment. So we'll talk a little bit more about transitions, but we provide very robust services and training, education, tips. It's a very thoughtful process for transition. Go ahead, next slide. Regional center services and support, residential, of course, everybody when they're admitted to a regional center, they are being provided a home where they're living, one of our group homes. We do have physical, occupational, speech therapy available, not at every regional center, but most of the ICF homes. We can consult. Like we have therapists that, for example, work at Wheat Ridge Regional Center. And they might consult with Pueblo Regional Center who doesn't have their own on-staff therapists. Health and psychology, that's also a little different at each regional center. For example, at Wheat Ridge, we have physician's assistants, we have a nurse practitioner, we have an overseeing doctor, we have nurses at all regional centers. They're assigned to each home. So that includes the DD waiver and the ICF homes. Bridges program is a program we combined the supported community connections or day program and supported employment services into that bridges model. People are actually able to work with DVR while they're at a regional center now, so they can look for community employment if they desire. Behavioral and psychological services, again, they're provided a little differently at each regional center. The DD waiver regional centers do rely more on community resources. Every regional center, whether it's DD waiver or ICF, does have board certified behavior analysts. There are some psychologists. Wheat Ridge does contract with a psychiatrist, and most people at the DD waiver homes see a community psychiatrist and or psychologist. Therapeutic recreation and community therapy. People are very integrated into the community when they're at the regional centers, so they do have many opportunities to access the community. case management and social work. Our team does a lot of social work kind of things. Case management is a official thing, actually. And for those of you that know about the community systems, the case management agencies, which used to be community-centered boards, they provide case management for individuals even when they're at the regional center if it is funded and licensed by DD waiver. When somebody is at one of the ICF homes, then we have staff members that take that role. They're the leaders of the team, so they do case management. If somebody needs adaptive equipment, we'll make sure that they get what they need so they can be safe with their ADLs. And then audiology, we have had audiologists on staff. I don't know if we do anymore, but if anybody needs audiology, we'd make sure that they get evaluations and any treatment. And really that goes for this is not in here, but anybody that needs a specialist. Obviously, we don't have a cardiologist at any of the regional centers, for example. So if they need a cardiologist, they will be seeing one in the community. Any questions about our supports and services? Okay, next.
Right.
You, Kelly, or?
Yep,
Yeah.
I'm going to
Okay.
talk about referrals because that's one of the main questions is how do you get referred to a regional center? So the case management agency is the hub for the entire process. And so that case management agency is going to make reasonable efforts to identify and explore any appropriate community-based option. So this is what Jen was alluding to earlier. And so what that looks like in practice, depending on your guys' level of lingo, we all know there's that 100.2 level of care assessment that identifies the needs of a member within home and community-based services. That case management agency is going to do a local and statewide referral for residential services on the developmental disability waiver to just establish, is there a least restrictive setting that is viable and safe that could, meet this person's needs. So that's kind of the bar that the case management agency is going to go through that process. Because again, we don't want someone to come into an institutional setting if they can be safely supported in the community. But if they determine, admission to a regional center needs to happen, that case management agency is filling out a referral form and putting together a referral packet with a lot of documentation on, the person's needs, assessments, medical information, kind of all those different things. And they're submitting it to us, and we have a central referral inbox that we maintain. And part of my role is actually to review these admission referrals to see if they meet our eligibility criteria. Eligibility criteria determined by state and federal regulations. Any questions on referrals? Let's go on the next slide. We'll talk about what happens after a referral. And you'll have to click multiple times so we can see the steps. So I'm going to review the referral and determine if it meets admission criteria. If it does meet admission criteria, then I'm going to notify the 3 directors at the 3 different regional centers that, hey, we got a new admission referral, and ask them to review, because they're going to need to determine which of their group homes can meet the identified needs of this individual. As you can imagine, intellectual and developmental disabilities is a wide spectrum of different needs. We have individuals with severe autism. We also have individuals with mild intellectual disability and borderline personality disorder. Certain populations cannot be well supported in the same home, not a good mix. So all the directors are going to review their current group home openings, kind of the makeup of the different individuals in there, the types of staffing and support, so that they can come to like a thoughtful conclusion on which home can best serve this individual. If I review the admission referral request and the criteria is not met, usually what we offer is kind of our community support team, which we'll talk in a little bit about, but offering, different ideas, brainstorming, like how could we best support this person in the community and kind of get through the challenge that is happening with the community team. So as far as the admission process, once we determine which regional center is accepting the individual, they have the best group home that can meet that person's needs, the case management agency is going to do a couple different things. They're going to petition for that imposition of legal disability to take away the person's right to choose where they live. And then if the individual is admitting into an ICF group home setting, there's a process through Telegen that the case management agency is going to submit their paperwork. Telegen is just making sure that regional center is the least restrictive setting and that everyone's done their due diligence. And then we move into what we call our pre-admission meeting, where we're talking about all the logistics of the person admitting to us. It gives our regional center teams a space to ask clarifying questions to make sure they thoroughly understand this member's needs. We plan for all the logistics for the admission. How's the person going to get there? Either they're going to be transported by a community provider, or they're going to use non-emergent medical transportation to get to us. We're going to work out, all those logistics. We're also going to do things, we're going to get signed consent. So even though there's an imposition of legal disability in place, individuals still need to consent to treatment with us, because we're going to be providing treatment. And so we're going to work with the individual, or if they have a court appointed guardian, to get treatment consents signed before they come. Any questions about the admission process? That's okay. Quiet group today. One of the questions we hear a lot is, how long does it take to admit to a regional center? It ebbs and flows, because as you can see, there are a lot of processes outside our control. There's a court process, there's review parties. On average, it's around 30 days, give or take. Just to put that in perspective. And even though these are situations that this is an emergency admission, it takes that amount of time just because there's so many steps involved within Medicaid, state and federal regulations, and all these kind of external processes that are in place. We can go to next slide. Lisa will talk about transitions, which are way more exciting celebrations.
All right, so transition criteria we've talked a little bit about already, but those are the goals that an individual is working on so that they can go back to community placement. We do have the behavior specialists that we mentioned before. Clinical behavior specialists, CBS is what we call them at the regional centers. They usually do an FBA, which is a functional behavior assessment. They really help to drive the goals, make sure they're appropriate and make sense for that individual. And they're related to barriers to community placement. So like we said, it's usually challenging behaviors that make it really hard to serve someone in the community. The behavior plan is also created by the CBS, and the whole team's involved in the development of that process. I mean, they write the plan with input from everybody that knows the person and the new team. And then we have our staff members that work at each of the homes. So they're the ones, of course, that are doing most of the implementation of the treatment plan, the behavior plan. That includes the other thing, the service plan with all the other day-to-day things, but also that behavior plan. So they implement the plan and they do tracking. And so we have a lot of data. Go ahead, next slide. All right, so when somebody meets their transition criteria, it's our team, the CS team, which is the community services team. We assign a lead person to work on that transition, which is me, and my role is a placement coordinator or one of my other team members. So we work with everybody that works with that individual currently. So all the regional center team members, the case management agency, the regional accountable entity if they're involved, natural supports if they have a guardian. I didn't mention the guardian before. So guardian, really anybody that is currently involved with the individual, they're the ones that we start that transition process with. And then as we're moving through the process and gaining those interested providers that are chosen for the community placement, then they are added to that team. So we start with the core team that's working with the individual now, and then we work towards finding all those community placement team members and include them in the process. So our team provides what we call transition support team services, TST for short, for a minimum of 90 days now, and we'll actually be able to do a lot more of that. This is a sideline thing, but we're going to be a transition coordination agency, so we'll be providing a lot more robust services when somebody leaves for a lot longer period of time.
And then
any questions about transition?
I did have a quick question, Lisa. Thank you. So you said that you're in the process of becoming a transition coordination agency?
Oh, yes, and I should have mentioned it, and probably Kelly or Jen has more details they'd like to share, but we're going to be a transition coordination agency. We talked about it today, so I know some of the details, that we should be active sometime around April. It's in the works, and we won't be doing transition coordination for anybody at nursing facilities. We'll only be doing transition coordination for individuals at the regional center going to community placement.
Perfect. Okay. And then are you going to work with, it sounds like the same population, just to clarify, or are you expanding your reach with that?
Oh yeah, so so people that are admitted at the regional center, that's our only focus group. So they have to start with being at a regional center for admission. And so that's at all three regional centers, Pueblo, Wheat Ridge, and Grand Junction. So they're admitted and then they meet their transition criteria. And then that's when we would provide that transition coordination support when they leave the regional center and go to community placement. So just our population, only people that are at a regional center currently, and then going to community placement.
Perfect. Thank you for clarifying that.
Mhm. Anything else you guys want to add, Kelly or Jen, with that?
And it's escaping me, but I know there's been some recent work to have transition coordination agencies do like diversion work and other stuff for members in the community. We're not going to be involved in that either. It's strictly individuals admitted at a regional center transitioning them back to the community because that's kind of like our specialty. And by being able to bill for transition coordination, we can provide more robust and long-term post-move transition support. Like that's the main reason we're doing it, because we want to support the folks, that, receive treatment at a regional center to be successful in the community and mitigate risk of them possibly needing readmission. Awesome. We can go to the next slide if we're ready. So we wanted to add for this group a little bit more about the developmental disability waiver, because we also know there are individuals with intellectual and developmental disabilities who are in skilled nursing facilities, and they may not be as aware that the developmental disability waiver could potentially serve them. It offers much more robust services than the other non intellectual disability type waivers. So they have residential habilitation services. That's 24-hour care. It's much more robust than those assisted living settings because they can provide fairly intensive medical care. Like we've seen individuals who need almost round the clock private duty nursing successfully supported on the developmental disability waiver. And that's because it has things called support levels, and support levels correspond to funding for the level of care that a person needs. And so that's how a lot of residential agencies on the developmental disability waiver can support individuals with more complex needs. There's applied behavioral analysis or behavior services. I just want to call that out because we know the term behavior services can kind of get lumped into the mental health and substance use field. But when we say behavior services, we're talking about that ABA with a board certified behavioral analysis, which can be really helpful for individuals that need some support with managing behaviors. The DD waiver has those day habilitation services, which is day program, support employment. There's transportation to access day program and support employment. And then I include the linked, this is HCPF's description of the developmental disability waiver and all the different services offered if you want to dive a little deeper. And then next slide, I'll talk a little bit more about the living settings. They're a little more robust than some of the other waivers. They have the option of family caregiver. So that is where a natural support, often it's parents or a sibling, but it can be any natural support, becomes the paid caregiver, and they're providing those residential services. The residential agency is employing them or contracting those family caregivers. But the family caregiver is paid to provide the day-to-day access to 24/7 care and supervision. And then this waiver also has host homes. Probably the best analogy would be kind of think of it like a foster home. It could be a married couple. It could be a mother and her son. They are opening their home. They have been trained in how to support individuals with disabilities, and they're being paid to provide care. The individual's living in a home in their room or is renting a room in their home. And so the host home is providing all of their care, supervision, and support needs. And then there are what are called personal care alternatives. It's a little bit of a catch-all category, and there's kind of two types that you see implemented in the community. There are apartment settings that are personal care alternative, and this is where a residential agency either supports a person who maybe has a housing voucher and they're living in an apartment, or maybe the residential agency is leasing an apartment and they're supporting the individual to live more independently in that apartment. So that's one avenue. The other one is 24/7 staffed PCA. Kind of think of it as like a mini group home. It's 1 to 3 individuals living together, and staff are rotating through in shifts, usually 10 or 12-hour shifts. So they're still provided direct access to 24/7 care, but they're kind of living in a little bit more more structured, in some ways more independent setting, because it's their home and the staff are coming in day and night to support them. And then there are still some group home settings operated. And this is the more traditional group home model where 4 to 8 individuals live in a home, and the residential agency staffs it 24/7 and make sure they have the supports they need. Any questions about the developmental disability waiver? Okay. Oh, and I will mention, like, because I was talking about medical, just because you guys are more skilled nursing facility background. A lot of host homes sometimes are, registered nurses or LPNs. So that's also kind of how they might support someone with more complex medical needs, or residential agencies have nurses on staff. So there are residential agencies that specialize in a complex medical population. So they'll have nurses and all those robust wraparound supports. And then there are residential agencies that support or more specialized in specific behavior. So there's some that work with problematic sexual behaviors and they have really thoughtful programs set up for supervision and support. Yeah. So yeah, wide array of different types of settings on this waiver. And so it can be very individualized, very flexible, and can really meet the targeted needs of the population. I think I'm done. I want to move on.
Okay, I think it's my turn. You guys did a lot. So I think we mentioned this early on that our team also provides a service called Community Support Team Services. So that is when we work in the community with someone struggling for various reasons, and we kind of join the team to provide some extra expertise and consultation. It's a free service. The case management agency is the referral source for these as well as admissions. And so this is when they're not looking for admission, but maybe just some guidance so that the person can stay in the community, which is really what we want. So we help with connecting to community resources. We can give tips. We can do training if needed, just education, recommendations from some of the professionals at the regional center. We always have a behavioral specialist on the team with us. And then most times an occupational therapist, but we'll also pull in speech therapy if needed, dietary, medical, depends on the referral and what the person's going through. But it's really meant to support the person and the team, and then also guide them if it's looking like the person might need regional center admission. So that can kind of cross over and we can help with that process as well. But we would do that as long as the case management agency is referring and the person's eligible for intellectual disability services, we can really provide that support to anyone. So even if someone was in a skilled nursing facility, we could even do that. Questions about CST? Okay, I think there's one more slide maybe. And we talked about this. So thanks, Lisa, because you did a great job. We have been approved as a TCA, a transition coordination agency. So we're really just waiting on one internal kind of red tape type of thing. And unfortunately, or fortunately, I mean, it's good for the regional centers, but we are only working with regional center individuals, but they still will have a choice, we should mention. So when they meet their transition criteria, they will be able to choose our TCA or choose to go with another TCA. We're hoping not, because we know the person really well and have a good rapport, but it is up to the person and or their guardian. So like Kelly and Lisa both already said, it's just going to allow for us to do more robust and longer transition follow-up and be able to bill for that, where we've just been doing it as a free service. So that's pretty exciting. And then I think that's it. We can open it up for questions. And then the last slide, just in case, I know you'll have access to this. It just has our contact information. And we do have an inquiry email, so you could use that if you think of questions later. At the very bottom, just general inquiries. We check that all the time. So if you know someone in the community, or you know someone at a SNF, or you just have a general question, we can always get back to you about something you think of later. And that's all we've got for, the formal presentation, but any questions or comments or anything we can clarify? And if not, that's okay.
No, thank you so much. This is really good information, because I know sometimes when we work on transitions, or even what what's available in the community. We tend to overthink or overlook regional centers. So definitely appreciate you guys coming today. But it sounds like, definitely correct me if I'm wrong, it sounds like technically the official referral process should go straight to the CMA first, just so they can do that comprehensive search, or do you guys prefer referrals to go straight to you and then you send it to the CMA?
We prefer you going to the CMA, but we're also here for all that collaboration. So it never hurts to like give us a heads up, or people email us all the time, and it's okay even if it doesn't work out that way. But yeah, the first step would be talking to the case management agency.
Perfect. Okay, thank you. And then I think you mentioned at your Grand Junction location, you guys do have someone who can help with guardianship. Do you mind speaking just really briefly on that?
Sure. Yeah. Her name's Julia. She's on this last slide. So she's part of our team based in Grand Junction. She's a court visitor in Mesa County, has a lot of expertise that way. And that's just, when somebody's petitioning for guardianship, a court visitor comes to talk to the individual and the potential guardian. So Julia does that. She's on the Colorado Guardianship Association. Is that what it's called, Kelly? I think. Yeah. So she has a ton of knowledge, and what she can do to help is more. So often someone in services with us who needs a guardian, the problem or the barrier is finding a volunteer, because to get like a paid guardian, it's hard for people at our facilities at least to be able to afford that. There's long waiting lists. So the best case scenario is if there's a volunteer guardian, and once that person's identified, she can really help guide them through the paperwork to file for guardianship. There's forms you can fill out to waive some of the fees for the court visitor, for the filing fee. And so it's more guidance she can provide, but education too. So if somebody's identified, I think I want to be this person's guardian, she can also just meet with them to talk about what guardianship is like and what's expected and the different types of guardianship. We can also educate people about alternatives to guardianship that are less restrictive. And you guys all probably know about all that, MDPOA and medical proxy and advocacy and things like that, supported decision making. So she can help. We can definitely connect people to her, and she can kind of just help guide that process. Thanks for asking. April, you have your hand up.
Yeah, hi, I'm April. I'm here in Pueblo. And so one of the transition agencies here. So a couple of things, because I just had a light bulb kind of go off. I think it would be really good that maybe at some point, Sammy, that they do a presentation on guardianship and the different guardianships. Because we do get a lot of questions about that, and it would be good, I don't know if Julian has time or somebody from that organization can do that. I think that'd be really helpful. And maybe even some literature, because sometimes, and some of the challenges that we have going into nursing homes is a lot of times they're like, oh, they have a POA, you can't talk to them. I'm like, well, there's a difference between a POA and a guardianship. So, even we have to educate nursing facilities as well, too. Not all of them. Some of them are like, yep, you're right and stuff. So I don't know if it's just new people coming into the nursing facilities or what that kind of looks like. But sorry, the light bulb just kind of popped in my head when you started talking about guardianships.
Yeah. Well, don't be sorry. It's a great idea. That's our team. We're always like, oh, where can we do a presentation or do some more education or just collaborating together? And I know what you mean. And even with a guardian, it doesn't take away that the person exists and you can talk to the person, it's definitely some nuances to all of those things. So I can talk to Julia. I think for sure that's something that we could do as a team, and Julia being the expert, and Kelly too, and all of it. We all have knowledge of these things, but just some of us have more than others. So we'd be happy to do that.
Okay. And then I oversee our ADRC here. So I'm at the Senior Resource Development Agency here in Pueblo.
Yeah.
So one of the things that I oversee as well too is our ADRC council meeting. So I'll probably send you over an invite. I think our next meeting is in April, I believe it is. So we would love to have you maybe do a presentation on the regional center as well too. So I'll shoot you over an email. But if I wanted to contact somebody here in Pueblo, who would be that local contact person? Because that sounds like.
Yeah, well, first the ADRC I'm aware of, and did we already? I think we already planned to present at one of those meetings. I think we talked about that with you, Sam.
We probably talked about it, yeah, but
Yeah,
we just
we
haven't
talked
made it
about it.
official.
Okay. Well, we can definitely do that. And we'll have to just see which meeting we could do that. Would be
Perfect.
similar presentation, but we can also morph our presentations based on what you think people want to hear, because we don't want to just assume, oh, this is, we're just going to throw information at you. We kind of want to tailor it. As far as like reaching out, it depends kind of on, I think Kelly really is the point person for the team. So
Okay,
that would be better. She can then filter like, what does this need? And if it is appropriate to send to Bonnie, who's our placement coordinator at Pueblo Regional Center, or is it a guardianship thing? Then it would be Julia. Like she can kind of help field whatever the need is. I'm a little bit more distant. I'm on the leadership team and not quite as involved in the day to day, but Kelly would be a good contact, I think, if that's okay, Kelly, to
yeah,
field
Yeah.
personal, like if you reached out, if it's just a general, like you meet someone in the community, they're wondering, they can also email our inquiry email, but they can also reach out to Kelly. We're open.
perfect. And then
Yes.
this question is for Sammy. Yeah. So then, of course, I'm starting to think, and maybe I'm thinking a little bit too much. Would I play a part in anything that the regional center thing is doing? That's completely separate, right? Their regional outreach and what they do is different than nursing facility. Okay, just wanted to make sure because I was like, oh, okay, maybe this is something new coming up. So, okay,
No, you're good, April. Thank you for asking. And it's really just for you guys in your role of just providing that education, just more knowledge. Just so if someone in that population has any additional questions, if they do want to move into the community and then say they just need to know of a backup as a resource, just in case something were to happen. Yes, thank you, Casey. Then you could just let them know.
perfect. Thank you, guys.
Yeah, April, thanks for the questions. We love talking about what we do and how we can help.
Yes, and all of these slides will be posted on our website. And thank you for all three of you for coming and presenting, because I know this is definitely valuable information. And if I receive any other questions, I can reach out. It sounds like the point person, maybe Kelly, but I'll reach out to you and try to get those answered. But thank you so much for coming, guys.
Thank
Thank
you.
you.
We
Thanks for
appreciate
having
you.
us.
Have a
good
great
afternoon.
day.
You too. And
Bye.
then we are going to move over to our next topic, which is remote supports, which we're really excited about. Casey, go ahead, take it away. Oh, you're on mute.
Yes, I love talking. Sorry about that. My name is Casey Wardle. I'm actually the benefits specialist at HCPF, the Colorado Medicaid, for remote supports and actually all of the enabling technologies. So that would be medication reminders, assistive technology, specialized medical equipment, and supplies. So today we're here to talk about kind of remote supports. But if any of you have any questions on some of these other enabling technologies, you can feel free to email me directly. Happy to do that. So next question, or next slide. So I guess what we'll cover today, I'm going to kind of do an edited version since we only have about 10 minutes. And then I do believe you've had some remote supports providers come and talk to you. And then we can also have more as time goes on. But what we'll cover today is from Medicaid or HCPF standpoint, what is remote supports, and then also what you need to know, a few examples of remote supports. Much like I think they did a great job of talking how to do a referral to a CMA. I don't have as much knowledge, but I think what they talked about, and then I can get some feedback from you guys, and then also what to consider of like, who would actually be a good candidate for remote supports. And then next slide. So understanding remote supports, what remote, and we go next slide, but basically what we want to think about remote supports is when a member has certain needs or they're really good at using technology, they don't necessarily want someone in their house all the time, or they may not be assessed to a need to have someone in their house all the time, but they may have something where they fall a lot, or they have activities like they are able to bathe themselves, but they don't, and so they don't need someone to help do that, but they may need someone to call just in case something goes on or something like that. Same with cooking. So what remote supports are they must be live two-way virtual coaching or supervision or cues that can either be on demand, so as I said, like as a member needs, or also scheduled, so if they know they need help getting ready for work in the morning, they can schedule like a half an hour call during that time to help them set reminders and walk them, a live coach to walk them through. A big part that's included in the remote supports is this remote supports technology. For many of our members, this is the only way to get assistive technology through waivers. So this can be anywhere, again, like I said, fall detection, sensors on their beds for getting up at night, even some cases where there's cameras at the front door, or basically lights, lights that they can turn on with their voice. Basically anything that can help them live in their home easier, more independently, and then not have to be reliant on other people as much. That's really the hope of remote supports, is just to basically create independence, but then also to fill this gap of where you might be in a rural situation, or you might have it, you're in a transition from a skilled nursing facility to home, and we can't necessarily get all the in-person staff, but we've identified that certain technologies can be used to help this member transition to their home easier, faster, better, more safely. And so that for you, it would be the time to consider, can we use remote supports? Can we use technology to help this member transition more safely into their home? And the nice thing with remote supports is they can be set up relatively but quickly. It can, they can, depending on the provider and the team, you could have someone there, the technology within a week or so after getting onto the home and community-based waiver and being approved for services. Right, next. And I guess it's not the waiver anymore. It's, and I think we talked about it here, examples, I kind of went through these. So we'll go to the next one. I mean, the big idea is that the case manager team just needs to identify needs, and then if there's and that could be met virtually. So that's the big one. I think another key part here that I wanted to highlight is, this isn't an either or situation. You can use virtual supports for some things, and then often members will absolutely need the in-person support for other things. The only caveat is they can't be provided at the same time, and ideally not duplicative, but I think, we've determined that, if taking a bath and needing someone to help you take a bath, say once a week or twice a week, and then they can able to do it, and if they just need coaching some other time, those aren't duplicative, because coaching is just much different than the hands-on. And that's why this really isn't a telehealth delivery of personal care. This is very much its own service, because the outcomes are different, the needs are different, and who's providing it sometimes can be different as well. So next slide. I'm going to go through this quiz. We've had a lot of success stories. Colorado now has about 150 to 200 members enrolled in remote supports. I was just looking, we have about 8, 9, 10 providers now. Some kind of are more hybrid, where they're originally enrolled as home health agencies and now have taken on remote supports. Some are more monitoring based, so they're really looking at some of those health vitals, that fall detection, monitoring some of those, and necessarily not available on call. They're one-on-one. And then some are very service-based, where they're one-to-one support. That's the primary way, and then rely less on the technology. That's great typing, Casey. Sorry about that. I was doing this fast. And I'm not going to, to get these slides, you can go through the clips. There's also some clips on the website. So the next slide, we're getting close. We'll go through these. We'll take questions at the end. I think what to know for skilled nursing facilities is that it's available for anyone who is assessed for needing long-term services support, and most importantly, now enrolled in community first choice. It's not waiver specific, but what that also means is members who are residing in residential facilities, so members on the DD waiver, like we just talked, like the previous presenter talked about, would not qualify for remote support. So it's kind of like, in this case, an either or, do they need more facility-based care, or could remote supports and personal care be thought of together to support these members? I think thinking about this, who would do best? I mean, obviously it's open to any member. We are finding that, some members love this idea and some are like, no, I don't want to use technology. So you know, if you're working with someone who already has an affinity, you know, they on their cell phone, they like tablets or, you know, something like that, and are able to use technology, I think this is a really interesting, these would be the people I would be talking to, of like connecting up with remote supports of like, can we get an Alexa in your house or something where you can use these things to turn lights on, or, you know, help you prepare food, and that over time should increase independence and really decrease these in-person supports, and over time really, we hope, really help both meet the need of having decreased or having this like gap of personal care service like providers available all the time, where we can then use technology. I think also this is someone who, you know, really wishes they want to spend time in their own rather than someone in their own house. I mean, I think the classic stories are, you know, there's time, Jeremiah's, if you look into it, is like where they live with their parents, they really never were by themselves. And remote supports can often be gently introduced as a way of creating more independence, moving into their new home over time. It doesn't need to be an either or. So if they're in a skilled nursing facility, you know, you can have a situation where, well, maybe they're in one surgeon limit, and then you have remote supports kind of supporting this independence in a good way. And I think we talked about the other one is if there's a limited in-care person options, you live in a rural area, or they can't find someone to come in right away, this is a nice thing that can be set up pretty quickly. I think next slide, I think that the one thing is, you know, a couple things. Remote support should be only authorized at the member's preference or request, and it's only for participants who have the ability to utilize a particular system's request. So this can't be where a legal guardian says, oh, I think my son, or I think I think they would be great on remote support, let's set them up. This needs to be a place where the member absolutely is like, no, this is what I want to do. This allows us get not around, but still meet the final settings rules and really make sure that this is person-centered, that it's not necessarily something that someone's saying they should do. It needs to be always on the member's preference. They need to always be able to turn the technology on and off. You know, have the risk have and understand what the risk of the technology is, and how to use it. So the next question then would be also, they need to have a backup support in place. So you to make remote supports work in case something goes wrong, is there someone who can come pretty quickly and do a live in-person check? So I think that is the one thing, and this can both be paid or non-paid. It can be a natural caregiver, or say a neighbor next door, and you can have a call down line where you have the neighbor next door. Then if they can't be called, then you can have their their home health, and then that home health can actually bill for that visit if needed. And then you could also have like a last resort call emergency. And this, again, should always be approved and decided by the member and the case manager. Next. I think we went through that. Next slide. Yep, good, next slide. Going through these things. I think I could have deleted some of these. Yep, thanks. Question. And I think we're last couple, and then we'll maybe come back and we'll do questions later. Referrals and what to consider. I think we talked about this, what to consider. You know, if a member is transitioning next 30 days and is having trouble getting staff, this would be a time to look at remote supports. You just are working with a member who just has an affinity, wants to use technology, this would be a time to consider referrals. I think remote supports is you know, it's not for everyone, for sure, but I think with the right person, it can be really life-changing and a great way to create independence. You know, this is a time where I was going to open it up and, you know, kind of get some input from skilled nursing facilities, both on when you guys would be considered a referral, also then who you would refer to. So if you want to go to the next slide, I think there'd be two ways you could to do a referral. You could, next slide. You could do either a case management agency, which I think the previous presentation went through very well, and we refer directly to a case management agency, and then they would do a request for a proposal from the remote supports providers they work with. Or you can also go to the remote supports webpage or the Find the Doctor tool on HCPF and really just directly refer the members to the providers themselves. I think sometimes that's an easy way to do it as well. our providers all are pretty, understand how to do the referral process, and then can kind of also speak to what makes them unique and what can help the member. So either way is good. I think last question, I think we're going to get there. Next slide. Yep, cool. So this is my contact information. If you have all of the rules for remote supports can be found on that website, which is the Code of Regulations. And there's also, HCPF does have a remote supports web guide. And in there, in the remote supports guide, which basically outlines all of this. It hasn't been completely updated. It's still going through clearance. I was hoping we would have it updated by day, but there's a lot changing right now at HCPF. So this is something that's, will get updated as we need to it. But the information there is, besides the CFC stuff, all remains correct and relevant.
Well, thank you, Casey. Definitely appreciate it. And if I'm being honest, I didn't realize you can get remote supports up and running so quickly. That was surprising because I just felt like it would take longer. I know you still have to be approved for HCPF and that can
Right.
take a while, but to get up and running was pretty quick. So it's exciting.
Yeah, I think there's some great providers who can do it pretty quick and are really like, yeah, let's get this done. And I think that's a unique part about this remote support, especially for skilled nursing facilities who might have that gap and people are waiting. This can be something that can get it set up pretty well.
Yeah, and then I was just thinking, because I know ideally remote supports, I mean, it can be used in urban, but also rural and frontier areas. Is there any part of the state where they're just not available by chance?
I think the within the remote supports, they'll pay for some of the broadband, the cellular connection, and the Wi-Fi. So as long as they're in a place in the state where it's available at all, not that they're paying for it or whatever, but if it's so there are probably some really remote areas that maybe don't have cell service, but as long as there's cell service available or broadband can be there, that can be covered under the remote support.
Perfect. Okay. So you said either cell service or broadband, either
Wi-Fi.
or.
Yep.
Perfect.
So hopefully at this point in time, that's a very limited amount in Colorado, but we're still doing the best we can.
Exactly. And there's so much out of our control, but thankfully, everyone's working on, outreaching more of the rural areas. So that's awesome. Thank you so much. And thank you for kind of speeding through that. I thought you would have more time, so I apologize for that, but I definitely appreciate you coming.
Yeah, no problem. And well, like I said, we have some great providers. So if you have any more questions, I can come back, or we can bring some providers. They often, have their unique as well.
Awesome. Well, thank you. And thank you everyone else for coming. We definitely appreciate it. Like I said, this presentation, the recording, and the slides will be on our website probably within a week or two, just because it does take some time to get those posted. But definitely appreciate everyone. And then I will stay on just in case there's any other questions. But I hope you guys enjoy the rest of your day. Thanks, guys.